Today I'm going to the details about case control study. You have some idea about case control studies already, right? And now I'm going to go into the detail about it and refine the concept or ideas for case control study. For you, here's the outline. First of all, I'm going to talk about the rationale, about why we need to use this kind of study design. The advantage, disadvantage, and sometimes it's kind of a must to save time and money. So that's the background information about it. And then I'll lead you through about the rules for how to choose or select an appropriate control group. Also, it's important, or even more important, to know the rule for selecting control groups. And during the process of choosing case group and control groups, matching will be something pretty applicable in such kind of study design in the process of choosing the case group and the control group, which is a method for confounding control, remember? So if we worry about the confounding from something very basic like gender, and then we could try to control the issue of confounding by matching at the stage of choosing cases and controls. If we have a male case at the age of 30, then we could try to find another control, who is also male at the age of 30s. Okay, then in the end of the whole process of choosing study subjects, we are pretty sure that the gender structure will be very similar. Age and gender structure will be very similar to each other, and then gender and age would not be confounded anymore, okay, in the process. But we might need to learn some specific or more sophisticated statistical methods to perform such kind of analysis with a study design of matching. So I'm going to talk about it later. And there are some specific biases in case control study. Or I could say that case control study is more vulnerable from specific kind of biases, especially for recall bias. So you have to learn some idea about why it happens and how to minimize it, especially for recall bias, which is a kind of information bias. In the end, I will introduce another kind of study design, which is called the nested case control study, which is the best combination of prospective and retrospective cohort studies. So I'll tell you why it could take the advantage from both sides, from prospective view and also retrospective view with the data. So it's called nested case control study. I can tell you now that the case control study is nested in an ongoing cohort. That's how it could take the advantage from both sides. So that'll be the best choice or best attempt if you are trying to do your thesis for quantitative research. Okay, so first of all, may I remind you the idea about how to adapt the idea from retrospective or prospective view on the data. So if we start with the natural way, we just follow up a group of people who exposed to something or not exposed to something and look in this direction. This is so-called prospective. So we just observe and check their exposure status in the very beginning and then follow up for a period of time. And some of them might got disease, yes. Might not the disease there. Or the ones who are not exposed to something could also get the disease, like a non-smoker got lung cancer, right? Although it's rare, but it happens. It's maybe more possible that they are less likely to get the disease. So this is so-called prospective. This is a very natural way. What happens every day in the nature. So it's the general idea about cohort study, right? Okay, but today, the idea is that we look at the data in the reverse way. We define the disease status in the very beginning of your study. So at a specific time point, you try to find a group of people with the disease compared to the one without the specific disease. But these people, they are so-called control. Some people say that for the non-exposed one, also control, but it's kind of confusing. So I would suggest you to call them as exposed group versus non-exposed group in cohort study. Okay, to make it clearer that the case control study, in case control study, the cases are the one with disease, and the control group is the ones for the ones without the disease. Okay, and then we could check what happened for the exposure previously. So we'll just look back or look around about what's happening about exposure, to compare the disease group to the non-disease group or control group. So this is so-called retrospective view. Okay, so today we are focused on the retrospective view, or so-called case control study. So we've seen the 2x2 table thing for many times, right? Okay. And also I have introduced the cross-sectional study, which is very similar to case control study, or almost the same, but just tiny little differences. But the key point is that the advantage and disadvantage for cross-sectional study are very similar to case control study. And also the statistical methods will be exactly the same. Okay, so you just need to know the tiny differences between cross-sectional study and the case control study. But don't worry too much about all the other issues. So for a typical cross-sectional study, subjects were sampled at a specific point of time, which is very similar to case control study. We just identify their current or past disease status, especially when the disease is a chronic one. I mean, the status doesn't change too much, like hypertension, obesity. It's possible that people could recover a little bit, but not necessarily true. But generally, we are talking about a disease which doesn't change. The status doesn't change too quickly. A subject is assessed and often examined in relation to existing exposures. So this part is also very similar to case control study. In a typical cross-sectional study, the subjects were typically chosen without knowledge of the disease or exposure status. So in other words, we have no idea about the exposure or disease status at that moment. To avoid the problem about so-called selection bias, we are going to talk about it later. But for cross-sectional study, for certain level of chances, we do the screening for the whole community. So it's easy to estimate the prevalence of disease in that community. And then we measure the exposure level at the same moment. So sometimes it's called a prevalence study because we have the number of people in the community, right? So it's possible to calculate the prevalence. But it's not an appropriate study design to be chosen because if we are facing a rare disease, I mean, if the number of cases is very little in a community, or the exposure is rare, it will be difficult to get sufficient statistical power to identify the relationship. So it would be better to apply the study design for a disease with which is pretty common in the community, and also the exposure is common. Because of the issue that we measure the exposure and outcome at the same moment, so it's hard to satisfy the temporal relation, which is the only necessary one in the judgment of a correlationship, right? So it's difficult to differentiate the cause and effect. So it's purely about a study to identify association rather than the causality or causal relationship. So this is also the disadvantage for case control study. So they are pretty similar to each other, right? Okay, but for a typical case control study, so I've summarized everything about case control study in one slide here. So subjects were sampled by disease status. So it's a little bit different from the cross-sectional study. So we just identify, oh, you got disease, and you don't have the disease, and then I try to compare your exposures. And then we just compare the cases, or so-called the subject with the disease, versus control. There has to be suitable comparison subjects. But it doesn't mean they are disease-free. They could have other diseases, but they don't have the disease we are interested, like the cases, what the cases have. Okay? But because the other diseases might be potential confounders, right? So we need to measure those information in the case group and the control group, and then we'll be able to find a way to control the confounders. And then we just ask what happened at that time or prior of the exposures. So look backward about what happened for the exposure. But this kind of study design is especially applicable for rare diseases because we could find a way to identify disease which is rare by some other way, like case registry or in a hospital, in ICU, to identify rare diseases. And then we just need to find another group which is comparable to the case group. So it's very efficient in resources and time. So it'll be particularly suitable for master thesis, right? Most of you will graduate in 2 years. And if you have limited time and resources for your research. So if you want to graduate in time, case control study might be the best choice for you. It could be done in a couple of months or a year. Okay, but because of the issue that we don't have the denominator for such kind of data set, so we cannot estimate the incidence. Like what I said before, incidence is essential for the study of etiology or the causes of disease, right? But we can still identify or estimate the relative risk by the idea of odds, right? Odds ratio. So even if we don't have the denominator, we could still use the AD over BC to estimate the relative risk or odds ratio by the concept I introduced before. And for case control study, because of the process of choosing cases and control, especially for control group, is pretty susceptible to selection bias. I will pay a lot of time and efforts on selection bias next week. So today you just need to know that case control study are vulnerable to selection bias. And selection bias will be something that's not possible to control it. The only thing we can do is try to identify it and minimize it at the stage of the study design and data collection. It's not possible to say that I'm going to control selection bias at the stage of data analysis. No, it's not possible. So it's more about management, about how to make your study done properly to avoid or minimize selection bias. So the consideration and identification for selection bias is very important. Right? If you have no idea about the sources of selection bias, then you will not be able to minimize them or avoid them, right? So this kind of art. Okay, and it's also for a typical case control study, it's difficult to differentiate cause and effect again because of temporal relation issue, right? So this is the major disadvantage for case control study, and the best advantage is about the resources and time. So it's quick and more feasible as a master student. Okay, what about the rationale? Why do we need to have case control studies? Because this is generally the first step in searching for causes for newly emerging diseases, like what we did before for AIDS, acquired immunodeficiency syndrome. Back to the 1980s, we have no idea about the reason or the cause of the disease at all. So that clinicians identify a group of young people, male, who are very unlikely to have the immune problem at that age. Okay, so what they do? They perform a case control study to just use a questionnaire to go through all the potential possible exposures, blah, blah, and they identify that it might be some kind of sexually transmitted disease. But sometimes it's criticized that it's a case control study it's like fishing. Just try to scan or try to identify a lot of different kind of exposures about geography, about socioeconomic, blah, 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 everything. So it's kind of fishing. The more information or the more variable you try to do with statistical analysis, the more likely to have what? Alpha error, right? Which is fixed at 5%. So even if there's no correlation at all, and you just do it blindly, 1 in 20 you will identify a significance, right? That's so-called alpha error. So it's pretty likely to find a lot of the significant finding, but it's not relationship at all. It just happened by chance. So sometimes it's criticized as a fishing epidemiology. But then that's the first step. Okay. Though it cannot satisfy the temporal relation, but to some extent, it could satisfy all the other guidelines. Only the temporal relation is not possible to satisfy with a typical case control study. But all the other guidelines, like specificity or dose response, all the other guidelines possible to be satisfied. Okay, and relatively cheaper and quicker to find the answer. But I have to emphasize that the importance of selecting controls is equal to selecting cases, or even more important, because it's easy to define and identify the cases because they have, if you have a clear definition or diagnosis criteria, they will be easy, right? At least they have been diagnosed by physicians, right? So it's easy and pure. But in the process of finding appropriate control, sometimes it will be challenging because of a lot of issues. First of all, they don't have disease, right? So they are not there waiting for you to study them, right? And also the compliance might be lower. They are not willing to join your study because they don't feel anything about it. So it's pretty difficult to find appropriate control group. So you need to think about it, about how to get an appropriate control group in the process to make a better comparison to the case group. Okay, and also remember, do you remember that in the lecture about the estimation of odds ratio by the idea of odds suggested by Mr. Cornfield? There's a so-called rare disease assumption, remember? But there's no clear cutoff point for how rare is so-called rare here. Some people might say maybe 1 in 1,000 or 1 in 100. But recently it has been proven that it has no need to be very rare. So even 20 or 30% of the disease prevalence in the population is fine. They use the method for unbiased estimation and find out that not very rare is good enough to satisfy the rare disease assumption. So we can feel free to use the idea of odds ratio as a substitution for the estimation of relative risk. So we can make them almost identical to the estimation of rate ratio, which is the estimation of relative risk in core studies. So even for case control study, not very rare, is as good as the estimation of the rate ratio in core studies. Okay, to identify the association between the exposure and the outcome. Okay, so it's good enough to use the tool of AD over BC. Okay, so now I'm going into the details about the process, or what is the best way, or the rule of thumb to choose appropriate cases for a typical case control study. First of all, we need to define the cases with certain criteria. And the best way is to use the ICD-10 codes because it's universally identified for most of the countries in the world, maybe all the countries in the world. So if you just put or give the ICD-10 codes, so everyone, all the researchers in the world will have a common sense. You are on the same page about the diseases, which has been clearly defined. Okay, so you have to clarify the definition at the very beginning, and have to put it in words. Why you need to put it in words? Why don't you just, I say it, or I define it clearly orally? No, because we have to make sure that it doesn't change. It doesn't change. It cannot be easily changed by any other way. That's why we need to sign a contract, right? Although it's a computer era, why do we need to sign our name on something, right? It's because it's a document. Even if we're out of power, the paper copy could be saved properly almost forever, or at least for years, right? So the purpose to put them in words is to make sure that it doesn't change easily for a certain period of time. So it's pretty important for case control studies to remain the definition of cases from the beginning to the end of the process of the selection of cases. So it's important. Okay, and the potential sources, the first one could be done by population screening for common diseases, like hypertension would be a great one. A lot of people have no idea about their hypertension at all. Maybe 30% or even half of them have no idea, especially for people at a younger age. Right? In age 20, what's the prevalence of hypertension? Maybe only 10%, right? But very little of them, very little part of them has some idea about their blood pressure at all. Diabetes would be another story. It's possible that more than half of them have no idea about their diabetic because there's no clear symptom at all. So maybe half of them have no idea about their diabetes at earlier stage, stage 1 or something. If you want to perform a common disease, you might need to try to use the method of population screening to identify the people who are qualified to be your case in your research. Okay, and the other possibility is to use the hospital admissions for severe cases like brain injury. If you want to identify brain injury in community, you might not be able to identify anyone in a year, right? If the community is not too big. Okay, but if you wait in the ICU or the emergency department, you'll be much more likely to identify the cases with a brain injury because of the accident, traffic accident or occupation accidents, right? And the other thing is that in a hospital admission, that could be diagnosed or screened by some clinical facility like a CT scan or something. So we are pretty sure they have brain injury with bleeding or fraction on the head or something. Right? So we're pretty sure about they qualify the definition of brain injury. So that's another advantage for identifying cases in hospital admissions. And the other way is to use the disease registry systems. Like cancer will be a great example because I think in most of the country, especially for the developed countries, or even most of the developing countries, they have established the cancer registry system pretty well because it has been, cancer has been the top 1 causes for most of the country for decades. So that's something that for the public health, that's the task for the public health authority for almost all the countries to establish a cancer registry system. It's been going on. The first one is in America, SEER. Have you ever heard about it? SEER. That's the first cancer registry system. In 1980s, I think. So up to now, it's been 40 or 50 years. So with those information, we'll be able to identify the cancer incidences and the trend, the change over time, or so-called secular trend of cancer incidence over for years. So we could perform some kind of sophisticated analysis about and do the projection about what happened in the future, something like that, or age period cohort effect analysis. So a lot of things we can do with accumulated information from cancer registry. So it would be a great idea to identify a specific kind of cancer you want, even if it's rare. Okay. And infectious disease by law will be another possibility to identify the infectious disease identified in a hospital or clinics, like what we are doing for COVID-19, right? Or like new influenza. So it's all covered by the infectious disease by law. So the physicians or the hospitals or the medical service provider, they are required to provide, collect information for those diseases. So they have been clearly defined by CPR or some kind of the immuno blah 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 method assay to define it. Anyway, so it should be clearly defined too. But if you want to identify the cases from hospital or clinics, it would be better to get those patients from multiple centers because if we just try to identify those cases in a mono center, they'll be more likely to have the issue of representativeness. So in other words, the sample you have in a single hospital might not be representative enough to the general population you want to refer your research outcome to. Or even worse, it could be possible to have selection bias. Like what I said before, it's very unlikely to control it. The best way is to avoid it or minimize it. Since it happened, the only thing we can do is to assess the damage because of or the bias caused by the selection bias here. Okay, so the better choice is to use the multiple centers rather than a single center to identify the cases. But there's another issue I have to mention is that existing cases are cases, right? Incidence cases are also cases. right? Especially for chronic disease, the most prevalent cases might take the biggest part of them, right? But if it's acute disease, the incidence cases might take the most part of them, right? But if they did not die easily or quickly enough, then it will be more and more prevalent cases. So it's kind of, all the cases might be mixed up with the incident cases and the prevalent cases. So this kind of argument, or you need to consider, or you have to struggle about, I want to know more about the cause for the prevalence, or I want to know about the cause of the disease, right? As an epidemiologist, I prefer to use incidence cases because we want to know the cause of the disease rather than the cause of disease and why they survive, right? So there's always an argument about the two choices, the incidence cases versus prevalent cases. But for epidemiology, we prefer to use the incidence cases or new cases. So we could identify the status change during a very short period of time to make sure that they are the incidence cases that make more sense for the research about etiology. Okay, because of the concern. So for incidence cases, they'll be more useful for etiology. But for prevalent cases, sometimes it might be more about the people who survive. They have specific characteristics to survive. But it could happen selectively, or it could happen by chance, or it could happen for both of them. It could be selectively and also by chance. So mix up. It's very difficult to identify, to realize what's happened for those people, for the prevalent cases. So we prefer to use incidence cases for case control study for the purpose of etiology study. And the other thing is about how to choose an appropriate control group. And I can tell you that this is one of the most difficult practical challenges in epidemiology. Although they are simply defined as a group without the specific disease as cases in our study. But practically, there are a lot of issues to be addressed to make sure that they are appropriately chosen. First of all, the control should be representative to the non-cases in the target population. Okay? But the non-cases is not an idea, it's not a fixed idea, it's a dynamic idea, right? People might get a disease and without disease, and with a disease without disease again, right? It's kind of dynamic, or it's not fixed. It's very hard to have a clear idea about what is so-called a representative control group, which is representative to the non-cases all the time. Okay, but so how is the problem, right? How to increase or enhance the representativeness for controls, a random sample, right? During a appropriate random process. Okay, and we have to make sure that they don't have the disease, right? Then that should be good enough. Okay, the resources. The first one will be community control. If we could go to the community and ask them or check them to make sure they don't have the disease, then that could be one of the resources for community control. Okay, and the other is for hospital control. Not all the people in the hospital are sick. They might be there for health examinations. They might be there for vaccination. They might be there for other diseases, or like accidents or something. Then there could be potential source for the people without the specific disease we are studying. Sometimes you could have more than one comparison groups as a control groups. It could be a plus. It could be a blessing thing, because you might be able to answer different kind of answer if you have you have more than one control groups. Or you could make it sure that it's robust for the comparisons. So sometimes in some studies we could have more than one control groups. There could be 2 control groups versus 1 case group in a case control study. For example, you could have one control group from community and the other one from the hospital. And if both of them show similar story, then it will be more likely to be truth, right? In terms of the community control, the ideal situation is to perform a probability sample of the general population with a random process. That's how we define a random sample, right? Remember the sampling method, simple random sampling or multiple stage sampling or systematic random sampling, blah, 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 to make sure that they are representative to the general population. And those kind of the random process, you need to use the random number at a certain, even if you just do it in one stage, that's fine. That will satisfy the random process. But it's hardly feasible. Even if you perform a perfect random sampling by appropriate random processes, it's not necessary you could identify every single one, right? I use a perfect method to have a sample. But you need to find every single one to do your questionnaire and draw their blood or do the measurement on their body or something, right? But is it possible that you will identify every single one? No one can say that. So it's hardly feasible. In reality, we have no choice to use like neighborhood controls. Okay, but it's not very useful because of the birds of feather flock together, right? Higher socioeconomic status people live with other group of people who are also got high socioeconomic status. Okay, and sometimes we use the sibling or spouse controls, which is again is also likely they are too close, too similar to the case group in terms of socioeconomic status, right? And the best friend controls, again, right? Random telephone number dialing, maybe, but nowadays most of people don't pick up the phone, right? Because of there are too many weird things going on for the random calls. So generally I don't pick up the phone. I don't pick up the call without knowing who he or she is, right? So in reality, nothing really perfect because of issue of potential matching. So it's partially matching, right? Spouses or sibling or neighborhood. They have been matched to socioeconomic status, right? And best friend, who's your best friend? It's very likely they'll graduate from the same school, right? Yeah, so they've been matched for the education level, for example. So potentially they have been matched to each other. So they have a lot of common characteristics. So they are too similar to each other. So sometimes it's not a good choice. So it's potentially, it could underlie some kind of selection bias, which is very difficult to deal with. Okay. Although that happens, so we have to try to find some other way to find the control. One of the possibilities is the hospital controls. The advantage is, at least they are clearly defined, right? They have been admitted or visited a hospital for some reason, that's fine. But we are pretty sure they don't have the disease we are interested in, right, in our case group. Because we have the medical records, right, we could do some simple check to those controls to make sure they don't have the disease. Okay, and it's economical. They are there waiting to see a doctor, so it's more likely to identify them. And because they are bored, are you bored in hospital? Yeah, for most of the time you are. No matter you are just a relative of the patient or you are the patient. And for most of the time it's kind of pretty bored. So they might have better compliance to have someone to talk to, right? Disadvantages. The first one is that they might not be representative to the non-cases in targeted population. So if it's an issue about representativeness, that's not too bad. But if it's an issue of selection bias, that's very bad. You are doomed. You're in trouble because of selection bias. So you have a wrong control group, that's even worse than you have a wrong case group. And also there are a lot of difficulties in measuring exposure in patients. These patients here, these are control, the ones without the specific disease we are interested in. They have a lot of issues like potential information bias or so-called recall bias because they had some problem, that's why they're in the hospital. So they might exaggerate the exposure status or something or they might exaggerate their other diseases or their risks somehow. That's so-called recall bias. Recall bias not only happens for cases, it also happens for controls. So when you're collecting information in case and control, you don't want them to give you selective information about the exposure status, right? So that's an issue for recall bias. And also, even if they are control group, you need to have the permission to access those people as a control. So you might need to have some kind of permission. You need to go through the IRB approval process, blah, 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 to access them. It's not the case they just walk in and then, may I invite you to join our study? You cannot do that. Sometimes it's very difficult. Sometimes you need to pay the hospital. The key point or the rule of thumb is to ensure they are comparable to each other in terms of the quality of the information. Okay? And we also need to measure precise information about their confounders for the purpose of confounding control at the stage of data analysis, right? Okay. But in the process of choosing cases and control, it's pretty feasible to apply matching, which is one of the typical methods for the purpose of confounding control, right? Matching is particularly applicable in case control study because that's what we are doing. We are choosing cases and control, right? And if you worry about some typical confounders, then matching will be a way which is pretty feasible for the purpose of confounding control. Types of matching. The first one, the individual matching. Like what I said, if you have a case who's a female at the age of 80s, they have to find a control who's also female at the age of 80s. Okay? And then you find another cases with a certain age and gender, then try to find another one with exact the same conditions of those kind of things. So in the end, 1-to-1, all the age and gender structure will be exact the same between the two comparison groups, right? Cases and control. And we don't need to worry about the confounding effect from gender and age. This is so-called individual matching. Like what I said, the controls were chosen by specific characteristic, which are similar to a case. But if you performed individual matching, then you need to apply, you have to adopt spatial statistical methods, which might be a little bit more sophisticated than what you have learned before. And the other choice is to perform frequency matching. So we don't do the matching one by one. So we just make sure that the proportion of gender and age, or composition or structure of age, are similar to each other. That's so-called frequency matching. So we just adjust the proportion of a specific factor equal to cases when choosing controls. So if the case is 80%, 20% for male, female, they just try to find another group of controls, also 80% male, 20% female. Okay, we just adjust the process in the process of choosing controls to make sure they are similar to each other. But it's not done at individual level, it's done at the group level. In that way, you don't need to adopt a sophisticated statistical method because it's not individual matching, it's frequency matching. But the issue about the residual confounding could still there. So you still need to adjust it. So it's pretty unlikely to make the perfect, 80-20, 80-20. It may be 80-20 or 70-30 or 60-40, something like that. So you might need to control the residual confounding from that factor at the stage of statistical analysis. But you could do it with the regular statistical methods. Just use the regular logistic regression or regular linear regression. They could control it properly. But still need to deal with it, residual confounding, or incomplete confounding control by frequency matching. Okay, but it's just, you can apply the typical methods. Limitations. It's not always possible to find someone to match to each case, right? So yeah, it's kind of sensitive to ask, why are you single? Why can't you find a girlfriend or boyfriend? Yeah, that's because it's not always possible to find someone to match, right? Yeah, for your study, if it's about dementia and you have the case at the age of 95, a male, right? It might be very difficult to find another control at the age of 95 without dementia, right? So individual level is not always feasible, so it's difficult. And the matching factor has no longer been available for assessing its effect because it's an artificial confounding already, right? So if something has been matched, then it's not available for the purpose of assessing its effect anymore. Because there'll be no effect because the adjustment by yourself. And also, if you abuse the method of matching, you might make them too similar to each other. I mean, the two comparison group, the cases and control. This is called overmatching. So eventually, you will find no significance at all. So all the odds ratio will be equal to 1 or similar, very close to 1 without any significance. Right? This is called overmatching. It happens. So even if you are trying to use matching, don't push it too much. Don't abuse it. So generally, we only use the matching on 1 or 2 or even 3 factors. It's very unlikely that you can match on 10 variables, right? If you do, then they'll be too similar to each other. Okay, and it could be time and money consuming. It takes a lot of time to find appropriate control to match to a case, right? And you might need to spend a lot of money, make a lot of calls, and try very hard to find the appropriate one in the medical records to match to the cases. So perfect matches does not exist. If you do, you need to spend a lot of money and time and efforts. So not very feasible. So it's more applicable for hospital control because you have the medical records. And now there's a computer era, right? You could key in, you could search for specific people with specific characteristics as the potential list of the controls. So it's possible and more applicable to find a match for controls. Do you remember you learned how to measure the length in primary school or in school, right? Mm-hmm. Yeah. How are we going to do it? We use a rule to compare to the length of the object we are going to measure, right? And the control group just works like a rule in the exact same process for measuring the length. Like what I suggested before, if you want to perform individual matching in a case control study, and then you need to use a sophisticated or more advanced statistical methods, right? So if you use the individual matching, then what we need to have is the number of pairs, like the concordance pair and the discordant pairs. Concordance pair means that both of case and control are exposed or non-exposed, but they are not informative. What we do care is about the discordant pairs. So we use the inconsistent pairs for case and control because they're informative. So it's even more straightforward. It's not AD over BC, it's just B over C. So it's even more easier in terms of the number of calculation. Then we could estimate the odds ratio by the discordant pairs. That's the so-called advanced statistics. For this kind of the univariable analysis, we use McNemar's test. McNemar's. If you use the modeling, you might need to use the conditional logistic regression rather than regular logistic regression. Okay, but you don't need to worry too much about that. It's not covered in the final exam. Okay, talking about the biases, which is more likely to happen in case control study. The first one and the more important one is selection bias. If the cases are selective, then it just limits the generalizability, or it just makes the ability to generalize your research outcome to the target population might be limited. That's not too bad. But if you have the selective controls, then the whole estimation will be invalid. So you'll be, it's very hard to identify the direction of bias. So that's why we have to minimize it or try to avoid as much as possible. And recall bias will be something very likely to happen because we identify the study subjects on their disease statuses. And for the ones with the disease, they might exaggerate their exposure before. For the ones without disease, they might forget what happened before. So they might underestimate or give you the biased information. So it's kind of information bias. There are some difficulties to assess the direction and extent of the bias because it could be differential or non-differential. If it's non-differential, it's not too bad because it might just shift into null or shift into null. If it's differential, it would be very hard to find to see if it's make it stronger or make it weaker. And also the extent of bias is not possible to identify. So a potential way is to double check what happened by their existing records in medical records or some kind of records in a school or hospital or medical records in a health insurance data set, something like that, to double check. That's one of the potential ways. But for most of the chances, it's very difficult, right? Okay. And this is a case control study design, which is a specific one because it's nested to an ongoing cohort. So this is a typical, the upper part is a typical cohort study. So we just identify a study population and follow up for a period of time. At baseline, we try to perform a lot of measurement for the potential information exposures like serum or urine or other specimens and put in the fridge or refrigerator for further analysis later by some lab work. And after a follow-up period of time, some of them might develop the disease, right? And maybe most of them don't have the disease. Then we just simply compare the identified cases to a subgroup of selected control. They don't have the disease. Okay, so this is a core study fashion, right? But we do it with a case control study framework. Okay, so then we could check what happened afterwards. And also it would satisfy the temporal relation. Okay, so it's a suitable, the study design, nested case control study is suitable for exploring the hypothesis generated in the future. Okay? Because we have all the information put in the fridge. So we could, even if there's a hypothesis which is brand new, which has never been done before, then potentially it's possible that we could get those information in the sample, in the urine or in the serum or the DNA. Then we could do the study. And generally it's attached to an ongoing cohort. So that's why it's a prospective, actually. Although it's a case control study, but it could be prospective. And then that's why it could take the advantage for core study and case control study. Those advantages could be taken simultaneously. And also we could minimize the cost and time. Sometimes the lab work might be very expensive, right? But we don't need to do the examination for every single in the cohort members. We just need to identify or check the level for the cases and the subgroup for the control. So with maybe only 1/10 of them, then could save 90% of your budget. And also it could satisfy the temporal relationship in the judgment of the causal relationship. And it's useful for the studies on multiple outcomes. So if it's a cancer-free cohort or population and we follow up for 20 years, then we could work on various kinds of cancers, right? And we could use a single or several control group for better comparison. So we could even use one single control group to compare different kind of case groups for different kind of cancer, right? So it could save a lot of time and money. And because we keep the records, we have the records at baseline measurement, and also we keep the sample in the fridge. So we are pretty sure that the exposure happened before the onset of disease, right? So the possibility of recall bias will be minimized. Although this is one of the major concerns for biases in case control study, right? With the nested case control study design, we don't need to worry about recall bias because we kept the records, okay, at baseline. So it could ensure that the exposure assessment is valid. And all the skills we have learned, like what I introduced before in today's lecture, For all the normal case control study, statistical methods and skills, and the case and control selection or matching data analysis, all the same. So you don't need to learn more new skills or new methods in terms of data analysis, which is also an advantage. Okay. So if possible, case control study might be the best choices you can have for a master thesis. Okay, personal insight. Case control study is the most feasible one. So although it's very straightforward and pretty simple, right? But you are a student, so you might have limited time and money and resources. So it's the most feasible one, but it still satisfies most of the guidelines for the judgment of causality, except the temporal relation, right? So if possible, you perform a nested case control study. That would be perfect. It could satisfy for all the requirements for judgment of causality. Okay, so it's easy to conduct, but also easy to make wrong conclusions. The estimation of relative risk might be easily to be biased somehow, especially when you are choosing inappropriate control group. So you have tried your best to manage to eliminate or at least minimize the biases at each stage from the study design or data collection or data analysis. Or you can even use the sensitivity analysis to minimize the biases. So it's kind of a continuous process before it's too late. To save your time for the data analysis, it will be the best to do it right in the very beginning rather than come back and forth. And so nested case control study design is a better choice if possible. That's highly recommended for your thesis. Read my lips. Choosing an appropriate control group is even more challenging or crucial than choosing appropriate cases in case control studies. Cases is pretty easy. If you clearly define, if you try to find them in a hospital, then they should be fine. But for control, you might need to spend a lot of time and money and efforts to make sure they are comparable to your case group. And recall bias is very common in case control study. So any effort against it will help, like checking the information from records or something to make sure that it's not too bad. Okay. And be aware of the weak points of hospital community or community controls to make a better decision. You need to make the decision at the stage of the study design, right? And please be familiar with the superiority of nested case control study design. To know why it's better than the others, then you could take the advantage of such kind of study design to help you out. Okay, that's it. Okay, so next week I'm going into further for a more sophisticated part about selection bias and the details about how to perform the confounding control by Mantel-Hansel methods. It will be a little bit advanced based on what has been given today about selection bias, how to judge it, and how to minimize it. And another kind of the confounding control method in data analysis called the Mantel-Hansel methods. That will be the key points for the lecture on Thursday. Okay, so that's it. Now that's the lecture part for today.